you who have joined. We are hoping as we go on, we'll have more people joining. I don't know if it's the network, but I remember seeing about 47 people, and then now I see it's down again to 25 and coming up. Our colleagues from eHealth Africa, is there any feedback? Maybe there's a slight technical challenge over there. Can you just confirm that you can hear me as well?
Yes, we can hear you. Apologies for the issue. We had some technical glitch with that, but it has been resolved. So
Hello?
Can you hear me?
Okay, great. All right, thank you so much for that. So thank you. We have 55 participants now, and we're still going strong. So we'll just start the webinar immediately. So my name is Dr. Yetunde Abioye. I lead the National Lassa Fever Technical Working Group at the Nigeria CDC, and I'll be moderating today's panel session. Apologies, just let me know if my background is too noisy. But if you can hear me and it's good, I also like to see your thumbs up. Please kindly confirm that you can. Okay, great. So I think I can see. All right, so without further ado, just go straight forward into the introduction of the guest for today. So we have the Director of Surveillance and EPID here on the call live with me. And she has a very broad wealth of experience, even with the Nigerian Field Epidemiology Program, spanning across even medical practice to public health and so many other response to emergency diseases. She's also the lead for the Emerging Viral Hemorrhagic Fever Disease Technical Working Group. And she'll be giving a very brief welcome remarks while we proceed to introduce the other speakers on the call, and then we'll start straight away with the webinar presentations for today. Thank you so much, and over to you.
Okay, so thank you everyone for joining. It's my singular honor. Thanks to the IM here today for the great coordination, and I'm happy to be here. So briefly, as she has mentioned, Fatima Sali is my name, the Director of Surveillance and Epidemiology. This is so to welcome all of us to yet another session for the Lassa Fever webinar series. As we all know, historically, the Lassa fever periods spans from October and peaks around January, between January and May. So for this year, as always, it's good to put up our readiness mechanism in place, just so that we have this inclusive, all of a society, all of a community sort of approach, as we desire to continuously maintain or even reduce the target CFR of 10% that we all desire. Unfortunately, as we speak this year, the cases still counting. So far, we have over 9,000 cases, suspected cases of Lassa fever, and over 8,000 confirmed, which unfortunately, 175 deaths, with a CFR of 16.2% across 133 LGAs, of course, across 28 states in Nigeria. So it's worrisome, but I think with this readiness mechanism and together, once we together do this, we desire that if cases come, definitely we'll be able to be on the alert and detect quickly and give prompt treatment, so that the outcome at the end of it is to actually reduce the deaths of Lassa fever. So again, it's my pleasure to welcome all of us, and I appeal to all of us here to pay attentively, because we all learn together as we plan to mitigate the Lassa fever. And it's our prayer that this season we should not record what we've recorded in the previous years. We desire that this should be minimal. So once again, thank you so very much, and happy webinar. Over.
Thank you so much, Director Ma. Really appreciate your continued support, and especially the Lassa Fever Technical Working Group. So without further ado, we'll just go straight into the introduction of the speakers. Thank you so much, Ma. I really appreciate your presence and continued support. So we have on the agenda, we have 3 seasoned speakers, and we have, apologies, colleagues. Okay. Yes, so the very first speaker will be giving an overview of Lassa fever in Nigeria, and her name is Mrs. Lorna Williams Eneche. She's a passionate and accomplished field epidemiologist with over a decade of progressive experience at the Nigeria CDC. She plays a vital role in subnational support and leads the surveillance pillar for the Lassa Fever Technical Working Group. So if you always see our CTREPs being published on time, she's one of the key people in that sector. She's also been part of the effort to drive enhanced disease detection and response. She has an MSc in epidemiology, and she's also an alumni of the Nigerian Field Epidemiology and Laboratory Training Program. She's a certified intermediate public health emergency management fellow. Her expertise really spans a lot of areas, but then she has unwavering commitment to public health and has also been very instrumental in strengthening disease surveillance and outbreak preparedness across all levels of government. Our second speaker is Francis Ola. He's a data manager at the Nigerian Centers for Disease Control and Prevention, working in the surveillance department under the Public Health Information Unit. He holds a master's degree in medical microbiology, and he's an educationist. Bringing a strong multidisciplinary approach to his work in public health, Francis has been actively involved in several impactful researches in public health, including the ongoing CEPI-enabled 1.5 Lassa fever research program in Nigeria and the WHO-led vaccine impact or effectiveness of the new vaccine surveillance for rotavirus. He has a solid background in data management. He's proficient in utilizing a variety of tools and technology for effective data analysis and reporting. His expertise also spans to capacity building initiatives, having collaborated with teams to conduct training on the integrated disease surveillance and response system and the deployment of the surveillance outbreak response management and analysis system across health facilities in Nigeria. Francis' contribution have been very instrumental in strengthening the public health, surveillance, and improving data quality across the country, and of course, improving health security and also global health security beyond Nigeria. Our wonderful speaker, the last but not the least, is Mrs. Favor Makava Deniji. She's an experienced public health professional with over 7 years experience in development and public health sectors. She has specialized in disease surveillance, outbreak response, and health system strengthening. Since 2016, she has been providing essential technical support to Nigeria CDC, especially to the Lassa Fever Technical Working Group, contributing to key initiatives such as the 5-year strategic plan development, which we hope to launch very soon, hopefully next month. She has also played a vital role in the after-action reviews aimed at improving outbreak preparedness and response. Her collaborative work with organizations such as JAPIGO and Nigeria CDC and so many other organizations have also helped in enhancing real-time data capturing and empowering local health systems through capacity building and technical mentorship. She is driven by a passion for sustainable health intervention. Favor is committed to advancing public health outcomes and, of course, improving global health security across the country. So without further ado, I think I'll just quickly introduce the first speaker to make her presentation. Mrs. Lorna Eneche, you have the floor. Please, can we have her slides up? She'll be making a presentation. Oh, apologies. I think I've missed a very important thing on the agenda. Yes, so just a brief, please quickly go back. Yes, so the objectives and expected outcomes. So I didn't know the agenda was on the slide deck. So let me just quickly present the webinar objectives. Next slide, please. So yes, the objective of this generally, this is the second webinar we are having of the series, is to ensure that we improve awareness of Lassa fever in Nigeria. Lassa fever was first, when the virus was finally characterized, was named after the town Lassa town in Borno State, but then you see that the awareness is still not as much as it should be. So we need to make sure that we know that this outbreak occurs in community. That's one of our goals. The aim of this particular series is also ensure that we encourage early reporting from communities, promote enhanced surveillance. We know this is the peak period where we start having cases rise. How can we ensure that we have that enhanced surveillance and reporting for Lassa fever? And our expected outcome is that we want to see how we will strengthen linkages in Lassa fever surveillance and reporting between communities, ministries, departments, and agencies, because with the Lassa fever TWG is multi-sectoral and multi-partner and uses the One Health approach. So we're also looking at our dedicated treatment centers at the national, state, and LGA levels. We also want to make sure that we have our community-based organizations and private organizations being part of this as much as possible. So just a quick ground rules. Please, colleagues, ensure you respect everyone's opinion in the chat box. We also want everyone to behave with integrity and respect, have mutual respect and understanding for each everyone. Can we also ensure that we only introduce ourselves in the chat box only? And just to also ensure, even though we have colleagues that will be monitoring, we want to make sure that only questions in the Q&A box will be attended to, please. So we don't want to miss out on the several introductions to the chat box and miss out important questions. Please ensure that you put your questions in the Q&A box, and that's where we are going to be responding to that. Colleagues, kindly ensure you respect other people's opinion. The NCDC is committed to providing and enabling an environment that is very, very conducive for everyone. And we believe that through this initiative, we'll also make sure that we have an inclusive, respectful, and safe environment for all. So without further ado, permit me to quickly introduce the first speaker, who is a seasoned public health professional, a FEM fellow, and also an MPLT fellow. Mrs. Lorna Eneche, you have the floor. Over to you.
Thank you so much, IM. Good morning, our highly esteemed director. Good morning, colleagues. My name is Lorna Williams Eneche, and I'll be taking the session on the overview of Lassa fever in Nigeria. Next slide, please. By way of introduction, looking at the history and epidemiology of Lassa fever is an acute viral hemorrhagic fever that was first reported in 1969 when 2 American missionary nurses died after testing positive to the virus. It is a single-stranded RNA virus that has a zoonotic origin. Its known reservoir is an infected rodent, popularly known as the Mastomys natalensis. Predisposing factors to Lassa fever includes contact with surfaces or food being contaminated with rodent urine or feces, often during the post-harvest drying season of grains in the open, or improper handling of infected rats for consumption. Again, the annual Lassa fever epidemic being experienced in Nigeria is usually caused by the exposure to virus-infected fluid or excreta from rodents. We also see human-to-human transmission occurring, and this is usually due to close contact with infected individual body fluids. Again, Lassa fever is endemic to West Africa and has the potential to spread globally. It presents a serious global public health threat. And in Nigeria, in West Africa, Nigeria accounts for the highest burden of Lassa fever, exhibiting seasonal trend. Research has shown that annually, about 100 to 300 cases of Lassa fever occur in West Africa. And these figures are most likely to be underestimated, largely due to challenges related to Lassa fever surveillance, which includes difficulty in case detection as a result of the non-specific symptoms that are being observed by Lassa fever cases, as well as limited access to specialized laboratories in affected countries. The disease is seen to be occurring frequently and reaching its peak during the dry season, that's between November to April. And it has also been observed that Lassa fever may be shifting its prevalence from rural areas to major urban centers. Recently, non-rodent hosts such as birds, lizards, and domestic animals have been implicated to be carriers of Lassa fever virus infection. Lizard had the highest positivity rate by PCR from these recent studies, while cattle had the highest seropositivity, with pig having the lowest seropositivity. It is, however, unclear the specific impact these additional hosts may have on pathogen diversity and Lassa fever transmission. Climate change and population growth, which are the two big elephants in the room, could further amplify the threats being posed by Lassa fever transmission. Next slide, please. The World Health Organization classifies Lassa fever cases as suspected, confirmed, and probable cases. Who is a suspected Lassa fever case? Is anyone with one or more of the following symptoms: headache, fever, sore throat, cough, and either history of contact with excreta or urine of rodents, or history of contact with a probable or confirmed Lassa fever case within a period of 21 days of onset of symptom, or anyone with inexplicable bleeding. Next slide, please. While a confirmed Lassa fever case is any suspected case with laboratory confirmation of either positive immunoglobulin M antibody or the polymerase chain reaction or positive virus isolation, and a probable Lassa fever case is any suspected case, as we have defined above, but who died without collection of specimen for laboratory testing. Here we have a snapshot of the 2024 Lassa fever data in Nigeria. From January 2nd to November 17, 2024, Nigeria has recorded 1,077 confirmed Lassa fever cases, including 175 deaths. And this data was from 133 local government areas in 28 states and the FCT. Comparing this to what we have within the same period in 2023, 1,144 confirmed cases were reported, including 194 deaths, and this was reported from 26 states. Ondo, Edo, and Bauchi states accounts for the total confirmed cases in the country. 16%. While comparing this to same period in 2023, we had our case fatality rate at 17.0%. Next slide, please. Lassa fever has been with us now for over 5 decades, 56 years to be precise. The question is, what effort has been made in its control? What has changed over the years? And again, for us to ponder on the future of Lassa fever in Nigeria. Here we have the number and geopolitical disposition of states with Lassa fever outbreak between 1969 to 2020. It is important to note that between 1981 and 1988, no outbreak was reported in country. And from the 52 years under review, outbreak occurred in 33 years. Interestingly, from 1988 up until date, there has been no year where we have not recorded an outbreak of Lassa fever in country. The summary of this analysis shows an overall strengthening of the outbreak, which is hallmarked by the change from irregular to regular annual and from limited local to nationwide outbreaks. Next slide, please. Let's have the next slide. So coming further to recent analysis from 2020 to 2023, comparing Lassa fever cases in country. This was a thorough research that was conducted, having a total of 28,780 suspected cases reviewed from 37 states. And all the states reported at least one confirmed case, except Akwa Ibom, Yobe, and Kwara states. And out of these suspected cases, 4,036 were laboratory confirmed, and 762 deaths reported, with a case fatality rate of 18.9%. When we look closely at the table, we see that 2023 accounts for the highest burden of Lassa fever cases within this 4 years period, having a total of 1,270 cases of Lassa fever, while 2022 accounted for the lowest number of Lassa fever cases reported. However, 2023 had the highest positivity rate, which was at 17.5%. Next slide, please. Here we have the overall burden of Lassa fever outbreaks per state in Nigeria between 1969 to 2020. And here we observed something very interesting. We see Yenagoa in Bayelsa State colored green here, showing the only state that did not report any Lassa fever outbreak within this long years period. Let's have the next slide, please. And coming closer to our recent data, looking at the confirmed Lassa fever cases in country between week 1 to week 46, it is observed that Lassa fever occurred in 28 states in country. However, worthy of note here are 2 states that reported over 100 confirmed cases, which are Ondo and Edo. Again, there were about 7 states that tested suspected cases. However, results turned out negative, such as Sokoto, Kebbi, Zamfara. These are cases that are being colored brown as seen on the map. Let's have the next slide, please. What has happened between 2020 to 2023? Looking at the transmission dynamics of Lassa fever. Here we had these 5 states as our 5 high burden states: Edo, Ondo, Bauchi, Taraba, and Ebonyi states. We see Edo and Ondo states accounting for high number of Lassa fever cases to the tune of over 1,000 cases. However, Ebonyi, which had some low burden, which reported low cases of Lassa fever, had high case fatality rates between these years under review. In fact, case fatality rates as high as over 40%. And coming close to recent data for 2024, interestingly, Ebonyi is no longer on our chart as the top 5 states. We have Benue coming up on the board now as one of our top 5 hotspot states. Again, Ondo Edo still remains accounts for high number of Lassa fever cases, while Benue State accounts for somewhat low cases of Lassa fever. And here we have the LGA, 10 LGAs in country that represents our top 10 LGA reporting high number of Lassa fever cases. Let's have the next slide, please. A similar trend or seasonal pattern has been observed in the last 6 years between 2019 to 2024. We observe high number of cases usually between Epi week 1 to Epi week 12. And from Epi week 13, few cases are being observed. We observe a slope in our curve. However, cases begin to rise from Epi week 50 up until Epi week 12 of the next year. This has been the trend over the last years. And significantly for us in NCDC and partner, this trend has better helped us to position ourselves in responding to the Lassa fever outbreak in country. Let's have the next slide, please. All right. Lassa fever affects both male and female. And from our data, we see the disease occurring amongst the under 5s, the young and middle age groups, as well as the elderly. However, interesting to note here is age group 31 to 40 accounting for the highest burden of the disease among these age groups. Let's have the next slide, please. Here was a study or a survey conducted last year by the United States Center for Disease Control, screening over 30,000 persons from Abia, Enugu, and Imo State for Lassa fever. However, there was no confirmed Lassa fever case reported from the number of persons that were screened. Let's have the next slide, please. Key milestones achieved as it concerns the national Lassa fever surveillance include active communication with state team to provide technical support to them regularly. We also develop weekly CITREP and disperse nationally and internationally. We also have adequate manpower at the pillar level to support pillar activities. We ensure that presentation of surveillance data are readily available during TWG meetings. And of course, we promptly analyze our data for decision-making. And also, one of the strong achievements as well is strong collaboration with partners and stakeholders. Let's have the next slide, please. Some of the challenges identified at the national Lassa fever surveillance include lack of funding for surveillance activities, poor data quality from states. For example, we do not have data on Lassa fever symptoms and pregnancy status of confirmed Lassa fever cases. There is also late submission of data from the state to the national and poor funding to conduct evidence-based research. And there is also late approval and poor implementation of our incident action plan. Let's have the next slide. What are the way forward? Okay, Lassa fever control. In controlling Lassa fever, certain activities are required. Routine surveillance before outbreak is essential. Enhanced surveillance during outbreak is key. State preparedness and coordination of response should be optimal. And after action review should be conducted to know what went well and what didn't go well, and lessons learned during the course of the outbreak. States should also ensure preparedness and contingency plans should be put in place, and the training and retraining of healthcare workers. All right, these are our references. Thank you all for listening and over. Happy to take your questions.
Thank you so much, Mrs. Lola Ineche, for that beautiful presentation, very powerful, giving us a very clear overview of what Lassa fever has been in Nigeria and even beyond. So I think we missed a step because we're having some technical issues. The question and answers actually will be answered during the session for the Q&A on our agenda. Right now, we'll be taking the poll. Our colleagues from eHealth Africa, are we able to project the poll now?
Not yet. Just a moment. It's going to take some time.
No worries. So Vivian, please just kindly go back to the agenda so we can all see. Then after the poll, we can then have Francis Ola's presentation. All right, just a few moments, please. Okay, Elijah.
Yes, it seems to take long. Can we shift it a bit?
Okay, all right then. Like how many minutes do you need so that I probably just have an idea? Because we're actually supposed to have the poll before the first presentation.
Okay, and like 3 more minutes.
All right, so colleagues, just bear with us. I think you can go ahead and just bring up the next presentation just for us to get ready and see. Thank you, Vivian. Okay, so just a moment, please. Okay, so perhaps I think Elijah will just probably just leave it. We won't just be able to compare, but please let's just have the next presenter up. After this, we have one more presentation, and maybe perhaps after the Q&A, we can then have it. All right, so over to you, Mrs. Favor Makaba-Adeniji.
Thank you so much, RM. Please confirm that I'm audible and everyone can hear me. If I can get a reaction.
Yes, please go on.
My name is Favor Makaba-Adeniji. Good morning, everyone. I am honored to be part of today at the second webinar series, and I would like to specially recognize the Director of Surveillance, Dr. Fatima Saleh, for joining us. Your presence here, ma'am, highlights the importance of the different topics we'll be discussing here today. It is good we've seen the overview of the Lassa fever surveillance in Nigeria. So in the next couple of minutes, I'll be taking us through 3 components of the surveillance activities. They include case investigation, contact tracing, and active case search. Next slide, please. So what is case investigation? So by way of introduction, as soon as a signal is identified or reported, the officers who are responsible, and in this case, we're referring to the disease surveillance and notification officers, will need to go to the community or the area where that signal is gotten to do some form of investigation by using the case investigation form that is in situations where we do not have access to strong network connection. Otherwise, we're expected, that's the DSNs are expected to go with their SOMAS device to conduct a thorough epidemiological investigation on the suspected case that has been reported or for the confirmed case. Now, in the next slide, we'll be going into the different components of case investigation. The first thing we want to look at when we're conducting a case investigation is to ensure that we have the patient's information. This includes the name of the patient, the home address, detailed home address of the patient, and of course, the travel movement. We want to be able to get the travel history so as to ascertain where the source of the infection was gotten. Another key important thing to look at also is the risk factor. This case has been identified, has been confirmed to be a Lassa fever case. Is there an epidemiological linkage? We need to be able to establish that. And of course, data documentation. On the CIFs, we have key variables that should be entered when we're conducting case investigation. And my colleague Ola Francis, when he's going into the data management section, will speak more on the data documentation. Now, what is contact tracing? Contact tracing involves three major approaches. First, we need to identify the contacts. As soon as these contacts are identified, then we need to list them. Following the listing, a follow-up has to be done. And this is usually for 21 days. So we need to visit the home of the confirmed case so as to list the contact who must have had exposure to a confirmed case. Please, next slide, and let's see how these contacts can be managed. So based on the diagram on the screen, if we can identify Mr. A here, contact tracing will be seamless. We're also able to isolate the virus instantly and ensure that every other members or people who must have had contact with Mr. A is prevented from spreading the virus in the community or at the health facilities. Next slide, please. How do we conduct contact tracing? How do we manage these contacts that have been identified? Of course, we want to work with the contact tracing tool. We have the contact tracing charts. We have a temperature chart also, where we list the temperature that is being recorded from the contacts on a daily basis. We want to be able to ensure that the listing is done again using the contact tracing tool. Following that, we now need to monitor for a period of 21 days. It does not end there. As soon as your contacts are actually identified, your first thing now is to ensure that your contacts are categorized. And there are three major categories of contact tracing. Next slide, please. We have the category 1, which are known as the no risk. So this set of individuals do not have direct contact to the patient's body fluids. They are just major contacts. However, they still need to be observed. The category 2 are known as the low risk contact. These are individuals who must have had direct contact with a patient. It could be through routine medical care or by handling the body fluids of a confirmed case. The last categories are known as the high risk contacts. These are people who were unprotected, who have had unprotected exposure to the skin or the mucous membrane of a confirmed Lassa fever case. Next slide. For the daily monitoring, using the contact tracing form, again, we need to clearly state the name of the patient, the phone number, the house address. These are some of the components that makes up the biodata of the contact. And of course, the temperature is the temperature above 37 degrees Celsius. So you need to clearly list that as, and then look out for other symptoms. In the earlier slide, you saw the different symptoms that are suggestive of Lassa fever. So you want to be able to identify all of the symptoms and ensure that they are listed. And of course, based on the three categories, you should be able to identify which of the categories, the contacts you have listed, falls under. Next slide, please. So what have we learned over the years as far as contact tracing is concerned? In 2018, we observed that for every contact, for every case that is identified, we would have at least 15 contacts per case. But over the years, it's been sudden decline. What does this tell us? From the screen, you can see that from 2019 to 2023, which was just last year, there was an absolute significant amount of decrease in the average number of contacts per case. What you have note here is that a small percentage of contacts becomes symptomatic each year. However, the positivity rate among the symptomatic contacts are actually constantly high. So in 2018, we observed it 32.2% on the positivity rate per contact. Overall, from 2018 to 2023, we noted that 43.2% of the positivity rate among the symptomatic contacts are actually high. Next slide, please. Now, if you may ask, who benefits from contact tracing? Is it the family members or the healthcare worker? In actual sense, both the family members and healthcare workers are directly exposed to the virus, placing them at a higher risk than the general public. For the family members, one of the things that the contact tracing will actually help to do is the risk of close contacts. This can happen by caregiving responsibility, which exposes them to the infectious and bodily fluids of a confirmed case. Another thing that contact tracing would help the family to do is early identification and intervention. What kind of intervention are we referring to here? So when you are seeing symptoms that are suggestive of Lassa fever, that contact can easily be transferred or referred to a treatment center where the contact samples, of course, will be taken, and as soon as it's confirmed to be Lassa fever, treatment would commence. And also to mention that there's a part of the prophylaxis, exposure prophylaxis that would be administered. So even healthcare workers are constantly affected by the virus based on their occupational exposure. What are the challenges that were observed over the years? The decline in the number of identified contacts per case, as we rightly saw from 2022 to 2023. So what does it tell us? Is it that we're not conducting contact tracing as soon as a case is identified? Or is it because of hard to reach area? What are these challenges? We would really, really like to hear from the state team who are present on this call. There's also delays in initiating contact tracing, which could also lead to the transmission, inconsistencies in coverage across states, and hard to reach areas. Of course, there is high level of staff attrition currently in the country. So it is possible that new staff are coming on board, they don't get to receive any form of trainings on how contact tracing can be conducted. But again, we would like to hear from the DSNOs and probably our state epidemiologists. Next slide, please. So what are our recommendations to some of those challenges that we've observed? Is to ensure that, one, all contacts that are identified are followed up effectively. This is crucial to minimize missed cases, so these contacts are not in the community spreading the virus. And with the observation on the high positivity rate among the symptomatic contacts, it is important for early identification, prompt testing, and administer treatment to further end the spread. Worthy of note is the integrated approach. Surveillance needs to work closely with the risk communication. Surveillance needs to provide targeted data that would inform targeted or enhanced risk communication and social mobilization activities at the community level, so people are well sensitized of Lassa fever and ways at which it can be prevented. Next slide. The second component of the surveillance activity is active case search. Usually this is a routine task basically what it requires of the DSNOs is to go into the communities and health facilities, next slide please, to check for cases that are suggestive of Lassa fever. You have states that has been silent, that has not recorded any suspected nor confirmed case of Lassa fever in the past years. You need to go to those communities and do proper sensitization and investigation. You review the records, the health records and registers at the health facilities. Good thing, we'll be launching the community-based surveillance strategy, so we can utilize the community informants in areas that are hard to reach. And because these people, the community are familiar with them, they'll be very open to give out certain information. And when we're conducting active case search, we need to bring in our probing skills and our listening skills, so that when we talk, these people listen and we also take their feedback. Next slide, please. So as general recommendation, yes, we know timeliness matters, as this would also reduce and increase the secondary, in a bid to reduce the transmission at the community. Once we see something, we need to report. These are the kind of trainings we want to be giving to the community informants. And as DSNOs, timely report is really, really key. And we're kindly encouraged to report these on SOMAS. We want to also focus on collaborative partnership. This was extensively discussed at the just concluded annual disease surveillance and response. Surveillance is a teamwork. There are lots of activities that the states need to be able to do, but can't do all by themselves, as we need to collaborate with all their partners, hence the need for hotspot mapping of partners and stakeholders at the community to see areas in which they can support to control the fight against Lassa fever in their respective states. Thank you for listening. I'll be happy to take questions and comments.
Thank you so much for that wonderful presentation. Just like we've always said, we'll take this Q&A session at the end of the third presentation. Thank you so much, really appreciate, and that was a beautiful one. I believe we all have an idea, overview of how contact tracing has really helped with Lassa fever preparedness and response. So please, let's have the next presenter up, please. Yes, so over to you, Francis.
Okay, good morning, everyone. Good morning, IM. Good morning, my esteemed director, and also my esteemed colleagues on the call. My name is Francis Ola. I'll be presenting for data management and also the reporting tools used for SOMAS data management. Next slide. Now, data management, which serves as the central documentation of the work we do. What is data management? It has to go with the systematic collation, organizing, analyzing and sharing of health data which ensures the security and also the timeliness for decision making, and also for controlling health threats, and also for public events. Now we need to understand the data element. What are the data elements we need to understand here are: one, the method of which these data are being collected, and also the system involved in the processing of this data, and also the validation and the quality of this data being collected, and also the application used to analyze the data being collected, and also the database which is used for archiving this database, and the storage of this data needs to be well known and equipped. Next slide. What are the importance of the data, public health data we use for Lassa fever in NCDC here? One, first of all, we need to talk about the Lassa Fever International Conference, which was held in 2019. We talked about brought together various professionals. We have to go with evaluating the impact of Lassa fever in country. And also we need to understand the use of our data to determine their public health intervention in terms of preparedness and position of logistics during preparation period and also for outbreak periods. We need to understand monitor the progress of health data management across board for routine investigation and also for reporting. We need to determine the areas for target for intervention. We need to understand which states, which LGAs have reported, just the way my colleagues Lana presented. We need to show where intervention is highly needed at the moment. We need to determine the barriers of Lassa fever outbreak, and also to which the data set influence public advisory and also for development of research intervention. Recently, the Enable 1.5, which of in Nigeria here, the surveillance data is being used for study mapping of the areas used for the study. Now, the structure of data management in NCDC cannot be overemphasized without the mentioning of the data tool being used for data collection, which is known as SUMAS. What is SUMAS? SUMAS serves as the surveillance outbreak response management and analysis system. It serves as the primary data tool which we use to collect all our priority disease in country, including Lassa fever. Now, what is this SUMAS platform used for? We have in this SUMAS platform, we have specific various case investigation forms, which is specific for Lassa fever. And also in this platform, we also have the case management module. It has different modules that covers that, but we talk about a few of them, which is just mentioned here. The contact trace and the monitoring form, which is used to monitor contact and also monitor contact of suspected cases and also for confirmed cases. And also we have to work in hand with our laboratory report, which is being generated from the testing laboratories in country, about 8 of them currently testing for Lassa fever in country in Nigeria. Next slide. Now, what are the key objectives of SUMAS? The key objective, we cannot say that without looking at the timeliness of the usage of it for reporting of surveillance data because of this complexity of the data we report, and also its usage in disease outbreak and response management. We need to also look at the function of it being ability to analyze our data and also for reporting. And also this application is user-friendly. And also this has also been done because of the work being done in the user interface and also the user experience. Now, the data entry steps on how data get into SUMAS. At the head facility level, we have trained personnel. We were able to detect suspected case of Lassa fever or a reported Lassa fever is being signaled to them at the head facility level. They should be able to use their tool to enter the data into the platform. And this data, the SUMAS has two interfaces. First is the mobile interface. The mobile app interface, which allows you to enter data where you have limited access to network, where you can collect data and later on sync it into the database. And also we have the web platform, which allows you to enter the data and also supervise the activities of data in the platform. And also the laboratory integration of this data in the platform, also which serves as the sample management module on the platform, which is also linked with the laboratory information management system. And also this data being transmitted into the SUMAS central database, it can also be exported in CSV format, which we can use for further analysis. And also when also this data is being shared to other partners or participants, we make sure this data is being anonymized. Next slide, please. Now, the validation and analysis of this data could be done by the surveillance and data officers entering the data into the platform. It could be the DSNOs and also the state epidemiologists at the state level, which serve as the central chief, and the state DSNOs serve as the central chief for data management at the state level. And also the follow-up, this system also has the tax management system, which generated automated tax for reporting of data in the system. And also it has this reported data generate automated reports, trends in terms of chart and also chart maps which create for public health decision. And also one other thing we need to know here that for the visualization also, we have a tool which is called the Data Analytics Visualization Tool, which is DAFT. Now this DAFT was early developed in 2022, launched in 2022, whereby data is being visualized through the data that was synced into the SOMAS platform. And also recently, this data analytics visualization to DAPT was recently deployed to 10 states in the country. Next slide, please. Now, this dashboard shows us what the SOMAS platforms look like. You can see from the right-hand side, shows you the surveillance dashboard of the SOMAS platform, and also from the left-hand side, shows you the dashboard for the DAPT page, which shows us the summary report, the data quality dashboards, and all what I've been talking about, the aggregate data for IDSR, OO2, and also other functionalities which it displays from the data it pulls from SOMAS. Next slide. Now we'll be talking about the Lassa fever case investigation form. What is this case investigation form? I would like to run briefly into the case investigation form, which Favor talked about extensively. If you observe from the presentation Favor made, she was talking about this CIF. Now, where is this CIF domiciled? This CIF is domiciled at the health facility and also in the treatment center where cases could be picked from. And this CIF has 7 different sessions. One, the first session talked about the reporting health facility, which has some variables there which must be filled. And also the second section talked about the case location, talking about where this case is being where the case address and also where the case is being picked from. And also we also have a variable there. We talked about the geolocation of the case, which also we can use that for further analysis, further geospatial analysis on our for our activities. And also the third session talks about the patient case information and details. Now we have to make sure that all this information are correctly collected from the case, and also whereby the case is not able to collect, at least a caregiver should give appropriate information about the case. And also we have the fourth session, which talks about the signs and symptoms being reported by the case. Next slide. Now, the fifth session talked about the possible source of infection, which is talking about the epidemiology, the travel history of the patient so far in the period of the last 3 weeks. And also the sixth section talks about the laboratory specimen sample information about the case and also the results being gotten from the case. Now, this CIF and also the last section talks about the outcome and also the details of the case and also the outcome of the case and details of the case when discharged. Now, this CIF is very important at the LGA level or the state level down to the health facility level. All information on this CIF should be correctly filled, following all date format, and to make sure that this CIF is completely free to have a good quality data. Next slide, please. So now, who is responsible for filling this case investigation form? Now, we talked about that anyone who is well trained, any clinician who is well trained in the community to potentially investigate a potential case of Lassa fever, suspected case of Lassa fever, be it in the community and also in the health facility and also in the other designated treatment centers. Now, the case investigation is very important that we need to be filled because it could properly document the case at the surveillance system. It will understand the potential source of information infection of the case and also generate contact listing from those who monitor the disease. And also we need to look at something that when no case investigation is being done, probably there will be no contact listing. And once there is no contact listing, there will be no contact monitoring for follow-up. There will be no contact monitoring for follow-up. And once there's no contact listing for contact monitoring for follow-up or contact tracing is being done, then definitely we should expect more Lassa fever cases in the community or in our society. Next slide, please. Now, the data quality management we need to hear that is being characterized by one, the accuracy of the data being collected. We cannot overemphasize this data quality because this is a routine activity we do here at NCDC. We need to understand that the accuracy of our data is very, very important for us. We need to understand that this data being collected, we cannot give a false positive result for a case, or which could lead misled response activity, or giving a response of a male case being pregnant. That's a very, very false positive response we'll be getting. So we make sure that our data is being accurate in case based, and also the completeness of these variables is also very, very important to us, that we need to understand that all variables listed up must be properly filled and also completed by the LGA, DSNO, or the state team, or the hospital focal person reporting the case. Next slide, please. Now, this data also has to be reliable. We need to understand, does this case really meet the case definition as it was reported for Lassa fever? We need to be very detailed about this case. If the case meets the standard case definition, which was documented, and also to be reported as Lassa fever case. And also the timeliness of this data, the more quickly the data is being reported, the more quick or prompt action is to be taken. So we need to understand that all this, the timeliness of data is being very, very mandatory for us to report on time. Then secondly, we want to talk about something different here, which talks about the standard data quality review meeting being held monthly here in NCDC. It's a meeting which we carry out monthly to review the surveillance data quality of performance report, which is also being done with about a couple number of about 18 states in a monthly manner, to also determine the consistency of the data they report, and also the timeliness of the data they report, the availability of the data they report, and also the completeness of variables, and also the completeness of reports being reported from the state level. And also their state data serve as the source data of which we match our data to do our quality data management on SOMAS. Next slide, please. Sorry. So this diagram here shows us the map of Nigeria, showing us the testing laboratories where we report our data from. As you can see from the map, we have each geopolitical zone being represented by one laboratory here. In Abuja here, we have the National Reference Laboratory in Gadua, which serve as a focal point for the North Central Zone. And also it just established a lab in Taraba, Jalingo, Federal Medical Center, Jalingo, which also has the capability of testing Lassa fever. And also we hope for more laboratories springing up in time to come for testing up Lassa fever in country. And also this data are also being received from this laboratory twice a week, Monday and also on Thursdays. And also we looked at also this data to analyze our data to publish our situation report. And also this data are also being reported daily in terms of outbreaks, or when we are in outbreak seasons. Next slide. Now, how does the surveillance and response workflow of SOMAS work? It works in three phases. One, which talked about the notification of the detect, which has to be with how the case is being detected from the community, or from the point of entry, or it could be from the hospital, the health facility. Now, once information is being passed across to the surveillance persons at the LGA level, or the surveillance person at the health facility focal person, it's quickly looked at it, and also we validate that data, and also to see how those cases can also be validated by this surveillance supervisor, of which all this information are being gathered and also entered into the platform, whereby the case is being taken care of, being isolated for treatment, and also for carrying out contacts of the case for follow-up. And also all this information are being done by the case supervisors and also the case officers. And also all this information are being synced into the central database for SOMAS in the case management module. Next slide. Now, what are the potentials we have achieved so far in SOMAS? SOMAS has had a way since its usage, and also it has been so helpful in the standardization of data, and also it has been used for the completeness of data being reported, and also the timeliness of data being reported. It has also been the detection and also investigation of response to outbreak or other public health event. We don't only use SOMAS for reporting of disease, we also use it to report event and also for other conditions. Now, it's reduced manual entry from paper sheets, which was very, very prone to errors, which we do observe here at NCDC. And also rapid transmission of data into the central database was seamless. And also the better management of data through provision of international security storage standard, which is following up the data governance policy, which was also being done. And also this platform has a way of generating data visualizers, which I mentioned earlier on, in terms of charts, maps, and also graphs, which have to go with infodemics of what we report on the system. So, and this generally has improved the data quality, which we get from the community. Next slide. Now, we cannot talk about all this we don't have any challenges. No, we have some challenges. And what are these challenges? The challenges as one as follows. We get late reporting from submission of data from the state and also from the lab due to some circumstances beyond their control, which also lead to missing fields on the CIF. That's one of the challenges, and also inconsistency of date format, because that's one of the major challenges we do have, whereby inconsistencies of this date format are being reported on the CIF, and also suboptimal integration of lab and surveillance data, which is a routine activity, though sometimes we do have that challenges whereby this number of samples being collected does not rhyme with the number of cases being reported. So that integration is one of the challenges we have. And also staff turnaround and attrition. Due to the DAPA syndrome we have in country, it's a very big challenge for us because you have trained officers and tomorrow the person is no more, and you need to retrain another colleague, and it will take time and also slow down the system. Next slide, please. Now, what are our recommendations? We encourage the states to take ownership of this data being collected at their level, and also make sure that the state has ownership on SOMAS, and also make sure that the state should properly use the activities and also report any functionalities to the national team so that measures and also solution could be brought to table. And also we need to ensure the completeness of the CIF. We cannot have, once our data is not being completed, that data cannot be used for any other analysis, and which will also slow our activities. The standardized date format in the CIF could have for avoiding consistency in the data format being reported. We also have to strengthen the integration between laboratory and surveillance data system, which has to link both the surveillance and data system to harmonize the collection of our case data and also our sample data. Now, the implementation of strategies to address staff attrition is very key, which needs to be which could be as such as training and also retention program to enable the staff at this subnational level and also at the local levels and also at the national level to prevent them from leaving their workforce for seeking for other jobs, which by will slow the activities of the TWG and also for the national activities. Thank you, and over, and I'm open to questions.
Thank you so much, Francis, for that beautiful presentation. Really, really appreciate every of the panelists so far. So Elijah, can we have the poll now? So we'll just have it once. So colleague, please kindly participate in the poll. I know we've had the presentations already. We're supposed to have this before and then probably after. So please feel free. The poll is up. I can confirm from my end that I can see the poll. So just a few minutes. We have 3 questions. So please kindly vote. So far, I think 9 people have responded. Okay, so we have about 11%. All right, colleagues, please just a minute to take part in the poll and okay, so we still need a couple more answers. I see so far it's just 45% out of I think 142 people that were on the call when it was shared. Can we get up to 50%, please, for the first question? And then we can proceed. So Elijah, once we have 50%, I think we can go ahead and project the next question. Just a reminder as well, colleagues, please drop your questions in the Q&A box. Only the questions in this box will actually be attended to. So please, please, please ensure to please answer or drop your comments in the Q&A box. Okay, so I think we already have over 50%. As much as would have loved to have more people, but we're also being time conscious. So thank you. So now the second question is up. Please kindly participate in the poll. Please kindly participate in the poll, colleagues. Thank you. So I think just the same way we had Elijah for the last poll, once it's 50%, we'll just move. So I think next time we'll just project one question before the presentation and then we'll go ahead, or we can take everything at once. So it's a learning curve for all of us, and then keep getting better. So once we have 50% for this as well, project the last question, and then we go straight into the Q&A. All right, colleagues, we have the last question up. Please kindly proceed to responding. Once we have 50%, we'll shut down all the polls and then go into the live Q&A.
The polls have been completed.
Yes, many thanks, Elijah. I think this is fine. We don't need to have 50% is good. We would have wanted more, but we're just making sure. So thank you. I think you can take down the poll, right? And I think, okay, so I think I'm just kind of sharing so that people can also see the poll. Though I don't know if that's able to, does everybody get to see the correct answer? I don't know.
Yes, it shows at the bottom.
It shows at the bottom. Okay. Okay. So show correct answers to all. I don't know if that is really necessary, or perhaps. Sorry. I think we'll just take this down. Thank you. So let's go into the Q&A session immediately. So we have some questions in the chat box that have been asked. So speakers, please, you have certain questions for you. I think some are very generic. So please, we'll need you to, if you could. And it says, what kind of screening was done by CDC in Abia, Imo, and Enugu? Is it symptomatic screening or laboratory testing? And you could respond in the light of enhanced surveillance, basically, for that question. So do you want to take all the questions for you or go over? I can see you've responded to some in the chat box, but I think it would be good for other people to also learn as well. Hello.
Hello, I am. I've been
Yes.
able to respond to some questions.
Yes, but I think it might be
got
good to
logged off
just
by the internet a while ago, so I used Francis' laptop to respond to some questions. I'm also checking if there are other questions so I can respond, especially for my session, so I can respond to it.
Yeah. So I think it's fine that you've responded as well.
Response is already
but
on the chat box.
yes, so we just wanted you to also just, I mean, so that other people can also learn from this. So if you don't mind, or if you, perhaps you're not available, then we could just move on to the next one. Okay, so Francis, I see there's a question for you around, I'm sure some of these questions might not just be related to surveillance though. But then just to also add, because I remember you had this map in your presentation where I think showing about 8 labs. Currently, we have 13 labs in the Lassa fever laboratory network. We're able to, from 9, which we had last year this time, we're able to move to 13. So 5 more labs were, yes, 5 more labs were also optimized. And I'm believing that when we have the laboratory pillar focus presentation, we can have more details here. Okay, so Francis, are you able to speak? I know there are some questions you've also responded to. Hello, Francis. Please, can anybody confirm that they can hear me?
I can hear you, I am.
Okay, thank you. So Francis. All right, Favor, so I think I'll just have to move on then to you as well. I really don't know what happened. Lorna and Francis are not available. So I know they've responded to some of these questions, and some of them, like even with regards to lab, it's not about it's not something that we can respond in this webinar, but then we'll take that feedback as well. So Lorna, I don't know if you could also talk about issues around the role which the community can also play when it comes to contact tracing. I know there are a lot of issues around risk communications and all of that. Just like the way we don't have issues going to test for malaria, or when people, I don't know, what is it about, and how can the community as well help to support contact tracing or make it the environment conducive or friendly? What is it about Lassa fever that sometimes people abscond or disappear or give fake addresses or fake phone numbers? Over to you, please. Hello, Favor. I'm actually wondering.
No, don't worry. I am. Excuse me. I'm watching now. I think I can address the question. And then, if I heard you correctly, you're asking what is it about that communities sometimes can be resistant to the treatment of Lassa fever. Is that what you said?
Contact tracing. What is the role of the community in supporting effective contact tracing? And I gave examples of people who drop fake numbers, fake house addresses, and how can we address this as well? Or how can the community support issues?
I think thank you so much, for that brilliant question. I think I also mentioned during the course of my presentation that this is where the strategy of the community-based surveillance will play a major role. Now, people from the communities who are community informants would help to sensitize. So if somebody is very much aware of the dangers that are attributed to Lassa fever, and the good side of it to know that once it is detected early and the patient or contact is transferred to a treatment center, that person gets to survive the virus. I think that with enhanced sensitization, which made me to mention then that there is need to have that integrated approach, both the surveillance and the risk communication. The risk communicators, they are very good at sensitizing community. So these community informants who are members of the community has a major role to play in informing the communities of the danger that are attributed to Lassa fever. I think something that we must commend during the risk communication series, there is a survivor, I think is being addressed as Baba Lassa, that everybody knows in the community. And I'm sure they even saw at the time he was sick, and this man is healed now and is telling everyone about the Lassa. If you have such people in a community and you have the DSNOs who are going there for investigation or contact tracing, I don't think there will be any resistance. So the community has a major role in playing by sensitizing these individuals. And we really, really look forward to the piloting and even the rollout of the community-based surveillance across the different communities in the country. I hope I've been able to address your question.
Thank you so much. So I think then we have a question. So please confirm that you can hear me, colleagues. Francis, Lorna, can you hear me? Because there are questions here for you.
Loud and clear. And
All
I was
right,
able
thank you.
to respond to some on the chat box.
Yes, but I wanted it to also be that you respond live so that people can also learn from this. There's just a recent question now, talking about your presentation, that when you say Lassa fever, the fever, what's the temperature alert? Because from the case definition, is it for a suspected case, right? Some of these criteria, is it 37 degrees or 38 degrees? So the person just wants clarity because the presentation, perhaps he had or she had 37. So please, over to you.
Okay, temperature rise above 37 degrees Celsius, and again, subject to clinician's physical examination. Thank you, and over.
All right, thank you so much. So the next webinar we'll be having is going to be on Friday, and the focus will be on case management. So I'm sure we'll have a lot of these questions also being answered in more details, speaking about the experts, talking from the case management and case managers, sorry, who are in the treatment centers. They'll be able to also answer more questions, but thank you for also giving that feedback. What about the question with regards to, okay, I think this one was for Francis, but he answered a bit and I'm not too sure if he's able to speak. Do you mind responding to some of the questions you've already answered in the chat, just to also ensure that, because not everybody might be able to navigate as well. So over to you.
Okay, thank you very much. I am. In response to some questions I got, which I responded to some of the clues. One, the last one I just responded to, if we have SOMAS being deployed to health facility. Yes, currently in the last few years, where SOMAS were deployed to all the 36 state plus FCT at the LGA level, the 774 LGAs. Now, SOMAS has also been deployed to some tertiary and also secondary health facility in country. As of this year, we've done about 6, and also planning is also ongoing to see how deployment can be done in other states. So hopefully at least we have 31 states which is on the pipeline to see how SOMAS could be deployed to their secondary and tertiary health facility. Thank you, and over. And also the second question we were talking about, if you can remind me, I'm trying to miss that out.
Yes, so I think the one with regards to, even though I know it's a question that is related to the lab, about do we have test kits, especially for high burden states where states are actively testing things that exhibit the same signs and symptoms to other viral hemorrhagic fevers or like malaria, just talking about early detection.
So for that, there is no approved test kit yet. What we do in country is laboratory.
Sorry, we can't hear you if you are speaking.
Oh, okay. Please confirm if you can hear me.
Now we can hear you.
All right, thank you. So for now, there is no approved test kits for Lassa fever diagnosis. What we have is laboratory confirmation via PCR. Thank you, and over. I'm sure we will be happy to receive and deploy test kits when it's been approved, either by WHO. Thank you.
All right. So I think just to clarify, we have test kits, but we don't have point of care kits, right? Because the Altona kits that we have is what we use for our PCR testing and so many other kits as well, carrying generic or samples, antigens that have been isolated from the Lassa fever circulating strain here in Nigeria. So for point of care diagnosis for Lassa fever, we don't have that at the moment. Quite a lot of researches are ongoing. I remember there was a time MSF also supported doing a research, but unfortunately our hopes were dashed. But hopefully soon we'll have this test kit, point of care test kit to clarify. But we have kits for Lassa fever, although these are not also manufactured in Nigeria. And I believe the laboratory presentation would answer the laboratory focus webinar that we plan to have, hopefully on the 13th of December, will provide more clarity. I also see some questions, even pre-webinar questions with regards to IPC. The webinar for IPC will also be coming up soon after the case management area of focus. So hopefully these questions will also answer this. So colleagues, thank you so much for your active participation and engagement throughout this webinar. It was really, really interesting, and it was good to also see the engagement ahead. Even before the webinar started, we had quite a number of feedbacks from the pre-webinar questions and comments. We also saw a lot of feedbacks live, you know, even the Q&A box, right? Where some of our colleagues have also, the speakers have also helped to just answer, but then also giving a feedback in general for everyone on the call to also learn from that. So it's quite a learning curve for us. And as always, we always love your feedback. I think a colleague of mine has already shared, Dr. Bello has shared the link, and Charity as well has also been sharing the link for the webinar evaluation in the chat box. We also have the QR code displayed on the slide deck. Kindly provide feedbacks with regards to the webinar. We really want to ensure that we use this to improve other webinars. We've also been doing social media sponsored posts with the support of Breakthrough Action Nigeria, and this will be a great opportunity to evaluate that and to know if we need to continue or just share within our regular platforms, WhatsApp, email, and all of that. So I think this will be very helpful for us to monitor and evaluate. So please give us feedbacks, the good, the bad, the ugly. We are happy to take them and improve our webinar series. So just key takeaways from this presentation: surveillance, data management, very, very key, and contact tracing, of course, very key to ensuring that we have, very good monitoring and evaluation, right? Whether before, after, or during. But then this is the readiness series, which aims to ensure that we get all actors in Lassa fever continuum of care, whether it's as a person, as a Nigerian citizen, or someone outside of this country, to be in that state of readiness to act. We have cases being reported in Nigeria all year round. From January to December, there is no week we don't have a confirmed case of Lassa fever. But the goal is to reduce the case fatality rate for Lassa fever. We hope that we've been able to meet our webinar objectives as we have clearly outlined. And we hope that this webinar, this particular series with focus at giving us the overview of Lassa fever in Nigeria, looking at the history, the issues around case management, contact tracing, and active case search, and the tools that we also use for reporting and monitoring this data, and even analyzing this data. We're also hoping that the community which we also live in, we all are members, right? Lassa fever is our business. Health security is our business. If you see anything related to the signs and symptoms of Lassa fever, please kindly reach the NCDC on 6323. And also, if you could also liaise or reach out to your local government disease surveillance notification officers, or even with the state Ministry of Health through the state EPI. And of course, we also have health facilities and dedicated treatment centers. So we'll hear more about this as we continue to progress in this series. And it's really been a pleasure being your host for this webinar. We are grateful to all our partners, eHealth, for giving us the platform, the USCDC for their support. We're also very grateful to JPIGO for their many support. We're grateful to Georgetown University for their support as well throughout this webinar. We're also very much grateful to our partners from IHV and Institute of Human Virology in Nigeria, also supporting the webinar. Our One Health MDAs as well, Federal Ministry of Health and Social Welfare, which is our parent ministry for the NCDC, the Federal Ministry of Agric and Food Security, the Federal Ministry of Environment. Really grateful for the support we've received. We can't also forget, right, to mention Breakthrough Action Nigeria through the USAID funding, who have also been supporting a lot of back-end social media posts, the banner design, and so many others. So we're really grateful to have everyone join, and we're also very grateful to have active engagement and participation. This is the second of the webinar, and I'm sure you're already enjoying the series so far. We still have a couple of more, probably up to 6 webinars running up until next year, because we've also tried to make sure that we also plan for the holidays and allow people to rest. But as much as possible, we'll see how we can also bring up this series quickly. So we're having case management on Friday. Hopefully the following week we have IPC, if this is confirmed. And afterwards we have the laboratory pillar, and then take a break and then come back in the new year with the presentation from Federal Ministry of Environment. And then we'll have one more presentation, just 2 in January, and then we wrap it up and go into full response mode. So we're very happy to have you all join, and our partners for their tireless commitment and engagement. My colleagues at the back end, your efforts have not gone unnoticed. Thank you for always troubleshooting and also ensuring that we have a seamless presentation. Quite a number of you, I can't mention all, but thank you so much for your commitment. So colleagues, until we see you next time again, please don't forget to do the webinar evaluation so that we can improve the very next webinar, which is coming up on Friday. And we hope to see you again by 10 a.m. on Friday, which is the 29th of November, 2024. Thank you and bye for now. Enjoy the rest of your day. It was a great pleasure being your host. Thank you and bye.
Thank you. Bye, everyone.